Good afternoon, and welcome to today's Navigating the Challenges of Aging. This event was organized by members of the Berkeley Emeriti Academy, who include Professors Phil Cowan, Michael Harris, Steve Siegel, Steve Shortell, and myself. The Emeriti Academy is an academic commons for retired faculty to gather, share, and create with the belief that ideas explored across disciplines nourish the life and mind and benefit of the larger community. The Academy fosters interdisciplinary scholarly pursuits such as mentoring, teaching, panel discussions, and service to the university. We'll have a link on the chat section for those who are interested in more information about the Academy or who in fact might be interested in joining. Now it's my pleasure to introduce Carrie Sweeney, Director of the UC Berkeley Retirement Center, who will be moderating this session. Carrie holds a Master's of Gerontology from Virginia Commonwealth University and has over 20 years of experience in developing and managing programs in geriatrics and gerontology, which are focused, aimed at improving the well-being of older adults. Carrie, let me turn the program over to you.
Great. Thank you, Ken. I'm happy to partner. The Retirement Center is happy to partner with the Emeriti Academy for today's event. And I welcome everyone. I love seeing some of the names, familiar names on the participant attendee list. So I'm glad you made time to join. I'd like to take a moment and thank our sponsors for this event, Belmont Village, which helps us increase our access to evidence-based health programs like today. The center is proud to be one of the 3 University of California campuses partnering with Belmont Village to bring lifelong learning, mentoring, and internship opportunities for students at the local community in Albany, which is a UC Berkeley affiliated senior living community. Just a little bit more about the work that Belmont Village has done. Their programs are based on evidence from research done with universities and healthcare partners such as UCLA, Vanderbilt University, USC Davis School of Gerontology, and recently UC San Diego. Programs like Whole Brain Fitness are focused on 7 essential elements, including the right nutrition, physical exercise, mental workouts, and lifelong learning, reduce stress, and strong social network and a sense of purpose. So to learn more about Belmont Village, we'll put the link, I think, in there, or we'll send it to you afterwards. It's belmontvillage.com. I'd like to share a couple of housekeeping items before I introduce the panelists for today. Today's event is being recorded, and we'll make the recording available to you, and likely the slides from today will be made available to you from the presenters. Please use the Q&A feature at the bottom of the screen to submit your question, and Dr. Pulse and I will be monitoring these. So I have the pleasure of introducing first Dr. John Newman. He's a geriatrician and an associate professor at Buck Institute for Research on Aging and in the University of California, San Francisco Division of Geriatrics. His research studies the molecular details of how diet and fasting regulate the genes and pathways that in turn control aging. Dr. Newman is also a geriatrician who cares for hospitalized older adults at UCSF and San Francisco VA Medical Center, focusing on preserving mobility and preventing delirium. And just a second after I introduce the other panelists, John will give his presentation on being your own geriatrician. Wendy Katzman is a physical therapist and a clinical research professor emeritus in the UC San Francisco Department of Physical Therapy and Rehabilitation Science. Dr. Katzman's research focuses on the influence of excessive kyphosis on aging, which is an increased spinal curvature in the upper back. She continues to collaborate on musculoskeletal research and mentor junior faculty. Wendy will speak about navigating aging from a physical therapist perspective. Christina Irving is the Director of Client Services at Family Caregiver Alliance. She's a licensed clinical social worker and oversees the staff of the Bay Area Caregiver Resource Center, who provide direct service to family caregivers, including assessment, counseling, education, and support. Christina's presentation will be about Family Caregiving 101. And Marilyn Stebbins is a pharmacist, a professor emeritus in the School of Pharmacy at UC San Francisco. Her expertise is in clinical innovations, particularly around Medicare Part D, health policy, managed care, education, and leadership development. Currently, she serves as the pharmacy director of Riva Health, a cardiovascular healthcare startup building the next generation of cardiovascular disease management. And she will talk about strategies on how to safely use medications across the continuum of care. I am so happy to have a UCSF group today. It's where I used to work in the Division of Geriatrics, and I'm so pleased that we could bring these incredible experts to our retirees for today. So I will hand it over to start the program with Dr. Newman.
Thank you, Carrie, and welcome everybody. Glad that you're all able to join us today. This is an amazing panel discussion that we have set up for you. And you'll see just why I think it's so amazing as we go through a short talk about how to be your own geriatrician. So as Carrie said, I'm a geriatrician at UC San Francisco. I'm also a scientist studying the biology of aging at the Buck Institute for Research on Aging. Not going to talk much about that today, but feel free to put questions in chat if you'd like. My clinical work is primarily based in the hospital, helping older adults to get through hospitalizations in one piece and to come out the other side, hopefully in better shape than when they arrived in the hospital. And that's at the San Francisco VA primarily. So geriatrics. Let's talk first about why geriatrics. What is geriatrics, and who am I talking to? Who is geriatric? How do we think about this? And then why do I think it's important to talk to all of you guys about how to think like a geriatrician? Why can't you just go see a geriatrician? So but let's start with the kind of more conceptual points of how do geriatricians think about what geriatrics means? I'm going to tell you about two key principles that kind of shape the thinking of geriatrics, how we think and how we think about the care of the older adults that we look after. One of these key principles is always having big picture goals in mind, treating the whole person. And this sounds like a platitude, right? You're a person, not a disease. But it gets to very nuts and bolts kind of stuff about how to think about what care makes the most sense, what's most likely to be helpful, because you can't do everything. When you try to do everything, you can wind up doing more harm than good. We'll talk about some examples of that. So everything needs to have a purpose. And the purpose is helping people live their lives. What are the big picture goals? What's important to someone? Maintaining their mobility, maintaining their ability to live independently, being able to take care of their grandchildren. What are their goals, and how do different aspects of their medical care either help them achieve their goals or maybe are not so important to their goals? But this idea of everything has a purpose. There's always a greater good that you're trying to achieve by making medical decisions. This is core to the concept of geriatrics. We'll talk more about this, and towards the end, how you can talk to your doctor about keeping big picture goals in mind and what's the purpose of the different things that you might talk with a doctor about. The other core principle, when geriatricians think about what defines us as a specialty, we often come back to complexity. It's always more than one thing. Everything affects everything else. As we get older, stuff happens. We kind of accumulate medicines, we accumulate diagnoses, and whenever there's a serious problem, something that's affecting our goals, there's usually more than one cause behind it. And a lot of the art and science of being a geriatrician and thinking like a geriatrician is trying to parse through that complexity to figure out what are the most important contributors and how can we turn just the right screw, tap just the right nail in order to address a bunch of stuff just the right way in order to achieve your big picture goals. So sometimes geriatricians think of ourselves as complexivists. The more complex you are, the more we want to see you and want to try to help you. So these are two of the things that help to define what geriatric means to a geriatrician. But you'll probably notice one thing I didn't say, and that's age. Age, as you know, we all kind of learn, is I think of the age that's on your driver's license is a pretty poor indicator, not very accurate, of how old you are in health terms or biological terms. It's really more about your complexity. So you can be a very young, very not geriatric at all 80-year-old. You know, you don't take very many medicines, you're independent, you run, you play tennis, or you can be a very geriatric 60-year-old, or even 50-year-old or 40-year-old. Age is not about what's on your driver's license. Age is about your health and your function. And so, you know, there's no age for geriatrics, but it's really about when goals become important, when everything is complicated. That's when geriatricians come into play. And really, the age on your driver's license, we're learning more and more, shouldn't define many or any of your medical decisions. To give a specific example, you know, I think we're all familiar with the idea that when we turn 50, which I'm not too far from, it's time to start thinking about colon cancer screening, getting your colonoscopy. When should you stop getting colonoscopies? What's the age on the other side? And it's a trick question. Thanks to research from my colleague Louise Walter at UCSF and many others, we know that there shouldn't be an age when you stop getting colon cancer screening. It should be based on your overall health. Colon cancer screening takes about 10 years to pay off in terms of reducing mortality from cancer. And so if you're likely to live for 10 years, no matter what your age is, you should still get colon cancer screening. It's not about age as a number. It's about your overall health, your function, your whole person. So why is it important to try to think like a geriatrician or learn how we think? Because having heard what I just said, some of you are probably thinking that sounds great. I would like to talk to a geriatrician, or I know a family member or a parent who might maybe benefit from talking to a geriatrician. But there are very, very few of us, far fewer than the people that we think could benefit from our help. There's fewer than 5,000 geriatricians in the United States, maybe closer to even 3,000 or so, versus about 50 million people who are over 65 years old. If any of you have tried to find a geriatrician for a family member, even here in the Bay Area, it's pretty hard. It's hard for me to find a geriatrician to refer people to. There's just not that many of us. We wind up, because of that, spending a lot of time trying to teach other doctors and other healthcare providers how to think like we do. There are a lot of geriatrician involved in education of medical professionals, doctors, residents, students, involved in creating systems of care and running systems of care and leadership at hospitals and healthcare systems, because there's just not enough of us to sit in front of everyone that we want to sit in front of and try to help. But having learned a little bit about today about how to think like a geriatrician, hopefully now you'll be able to go to your primary care doctor and talk with them the way that you would talk to a geriatrician. So treat people, not just diseases. Treating diseases has the purpose of helping to achieve people's goals, and individualized care for big picture goals. Not everyone has the same goals. Not everyone should get the same care. Everyone is complicated. The different levers that you and your doctor decide to pull are based on your priorities for your big picture goals. I want to dive into some detail about this idea of complexity, that it's never just one thing, because this really does define the science of being a geriatrician, and how we've learned how to kind of think about a system of care to help older adults meet their goals, stay independent, maintain their function. And the core of that are geriatric syndromes. If there's one kind of class of disorders, you know, cardiologists specialize in heart disease, pulmonologists specialize in lung disease, oncologists in cancer. What do geriatricians specialize in? We think of geriatric syndromes. And this is a way of kind of putting the rubber on the road and getting a little more concrete about how we think about problems. So let's start with a problem, a fall. Falls are very common. Many people fall. Falls can also be devastating. If you fall and fracture a hip or fracture a wrist, people can have a really hard time recovering from that. It can wind up changing lives. On the other hand, you don't want to be afraid of falling. You got to keep walking and maintain your mobility. So why do people fall? This is such a common thing. What's the reason? And that's a trick question. You might think, well, I tripped over that rug, or I slipped coming up the stairs, or I got a little woozy. It's never just one thing. There's always a constellation of factors that go into causing a fall. And you might think about that as both things that helped to cause the fall and things that didn't prevent the fall. And these are things that are at work in every different system of the body, right? So, and not just inside the body, but also things external to the person too. So maybe that bit of a tremor from early Parkinson's disease that made the cane less effective, or the atrial fibrillation that made the heart race momentarily and made someone a little bit lightheaded, or maybe a little bit of cognitive impairment, forgetting about whether the chair behind you had wheels or not. A vision problem makes it harder to see the floor or see that lip in the carpet. Arthritis in the knee, a little bit of pain at just the wrong moment, or maybe when someone moved to steady themselves that prevented them from not falling, or the peripheral neuropathy that makes it hard to feel where your foot is. All these things together can contribute in small ways to a systems problem of a fall. And not just the medical problems, but the things in the environment too, the medications that someone is taking. They will help, but maybe the blood pressure was a little bit overtreated, and someone got a little bit lightheaded. Or how's the environment set up? What obstacles were in the way, and how open was the path for using the cane or the walker? And were there caregivers around if someone needs help with their mobility? Or maybe someone with dementia who needs help with safety awareness. All of these things are different components that go into a very common, simple outcome of a fall. So every fall is the same, but every fall is different. How do you treat something like that? That seems just immensely complicated. That was just one example. Hundreds of other factors might be at work in any individual who falls. How do you even think about that? It's almost overwhelming. But the art and the science of geriatrics is to approach those complex problems in a systematic, multifactorial way. So in a simple way of looking at it, try to identify all the different factors in that individual that might have contributed to that fall. And we kind of make lists and prioritize which seem like they're most important, which seem like maybe they're there, but they're less important. Which things can we do something about? Which things can we not really do something about? And approach that in a very systematic, rigorous way. And then, having kind of put out this menu of things that we think are contributing to this systems problem, then try to treat as many of them as we can without causing problems in other areas. So this approach is called a comprehensive assessment, leading to multi-component interventions. And this comprehensive geriatric assessment is really at the core of managing all sorts of complex multifactorial problems as we age. So geriatric syndromes, these are common, impactful problems that are inherently multifactorial. It's more than one thing. It's always more than one thing. Multi-system. It's not just the heart, not just the brain, not just the muscles. It's everything together. Many of those factors are aging related. And the geriatric syndrome is kind of the final common pathway, the common integrative outcome, the result of all of that complexity. Falls are one example, but other examples are frailty, mobility decline. Someone is not walking as well as they used to. What's the cause? It's always more than one thing. That's a geriatric syndrome. Cognitive decline. Alzheimer's disease, for example, is a very specific disease with specific A to B to C pathophysiology, right? But cognitive decline is a geriatric syndrome that usually involves more than one thing going on. So yes, there's Alzheimer's pathophysiology, and maybe a lot of it. but there's probably also some vascular disease, microvascular disease. Maybe there's some other things contributing to it. Things like resilience from education, social connectedness, all these different factors that affect how that Alzheimer's disease manifests in a person and whether they actually get cognitive decline and dementia. So Alzheimer's disease is a disease which causes a lot of cognitive decline, but cognitive decline I think of as a multifactorial geriatric syndrome. And the big picture here is that geriatric syndromes are treatable despite this complexity. And we know this from gold standard randomized controlled trials published in the very best medical journals like New England Journal of Medicine, by using this framework of systematic comprehensive assessment guiding multi-component interventions. This stuff works. It works better for some geriatric syndromes than others. Some of the best data are for preventing the acute confusional state called delirium in hospitalized older adults. These are the examples I'm showing here. And you're welcome to ask me later in the Q&A about delirium, which is a topic that I both treat and study scientifically. But the same idea applies to falls, to cognitive decline, and to other geriatric syndromes. So this is how geriatricians think about complex multifactorial problems. So for the second part of the talk, we're going to switch gears a bit to what to do, what you can do about thinking like a geriatrician, and putting together your own comprehensive geriatric assessment and multi-component intervention to address challenges in your life. This requires a team, and this is why I'm so excited with the amazing panel that we put together for you guys today. Geriatricians' natural environment is as part of a team. We don't work by ourselves. We always work better as part of a team. And we'll talk about some of the elements of a geriatrics team in a moment. And when should you think about consulting your team, putting together your team? When you're getting ready for a challenge. So for example, if you're getting ready to run a marathon or to compete in the Senior Olympics at 103 years old, you're going to get ready for it, right? You're not just going to walk onto the track. You're going to have a program, get in shape, change your diet, exercise. It'll be a systematic program to get you ready for that big challenge. You should have the same mindset when you're facing a big health challenge. If you're getting ready for a surgery, if you've been diagnosed with a cancer and you're starting to think about cancer treatment options, this is a good time to get ready, to pull your team together, to do your comprehensive assessment and to make a plan to get in as good shape as you can for your health challenge. But it's also not a bad idea just to do once in a while anyway. Just like you might periodically pause and reflect on, things that you want to change in your life. Sit down with your doctor, pull together your team, see how things are going, see what you might change and what you can do better to get yourself in better shape. This is particularly important when you're facing a big health challenge like a surgery. And there's actually a lot of data behind this. The concept is called prehabilitation. And doing this kind of systematic team-based assessment and a multi-component intervention can help older adults get through challenges like surgery as if they were younger, by getting their whole body into better shape for their challenge. So what does a team look like? Well, in the hospital and the clinic, we often work in multidisciplinary teams that include doctors, hopefully a geriatrician, nurses, many of whom are geriatric specialty trained, but also physical therapists, occupational therapists, social workers, and pharmacists, and others, all of whom have special expertise related to older adults. And we always do best working together. When I'm in the hospital, I feel like when I'm just by myself, I can't make that much of an impact. But when I'm working as part of a team, where I have the social worker and the physical therapist and the pharmacist all working with me, we can make such a greater impact on people's health and lives. It's always better as part of a team. So this concept of prehabilitation and I should say, you guys have probably heard of the idea of rehabilitation. After a surgery, get back in shape. Prehabilitation is before the problem, before the surgery. Get in as good a shape as you can first. This idea of prehabilitation is using this multidisciplinary team to optimize your health conditions, to optimize your medications, to optimize your fitness, which is not just about being in good physical shape, but actually is a strong predictor and has a huge impact on all sorts of aging-related complications and problems. Being fit, being in the best shape you can, is one of the best ways to get through health challenges as if you were a younger person. Optimizing your support. Everyone needs help, and making sure that you have the help you need will help your recovery be much smoother. And optimizing your plan. If things go well, if things don't go well. Talking about advanced directives, for example. So these are all the key elements of a multidisciplinary prehabilitation plan. If you're looking for something like this I know many of you are not in the Bay Area. If you're looking for something like this in your own healthcare system, what do you look for? Even if your system doesn't have a geriatric clinic, you can look to see if your healthcare system is age-friendly. This is a national initiative started by the Hartford Foundation and the Institute for Healthcare Improvement, which is designed to work these kinds of geriatric principles into all settings of care, not just geriatric clinics, but every ER, every hospital, every ICU, every surgical suite, in ways that make them more friendly, more optimized for taking care of older adults. So look for age-friendly healthcare systems, or ask your healthcare system if they are age-friendly, if they're part of this program. And the age-friendly healthcare systems focus on 4 M's to optimize care for older adults. These 4 M's, which should sound familiar after I just talked about elements of multidisciplinary prehabilitation, include a focus on mobility, on mentation, on thinking clearly, on medications, the right medications, and not too much, and what matters, planning, advanced directives, goals. So look for the 4 M's in your neck of the woods, and you can look on there'd be some resources at the end where you can look for hospitals that are age-friendly. If you happen to be in San Francisco, UCSF and the San Francisco VA do have specialized prehabilitation clinics for older adults getting ready for surgeries. I think we're one of the leaders in this area in the country. You can look up the Center for Surgery in Older Adults, which has a nice website, or Enhanced Recovery After Surgery. If you're a veteran, the San Francisco VA has a similar clinic called the VIP Clinic for Veterans Integrated Perioperative Care. These are all clinics that have a multidisciplinary team, like I just described, going through all those different elements with you before you have your surgery to get you in the best shape possible. Now, if you're not so fortunate to have a hospital that has geriatric clinics and prehabilitation clinics and be age-friendly, you can try to put together your own team. And some suggestions for this, you can talk with your doctor, who maybe is a geriatrician, maybe isn't, but you can have a conversation with them along these sorts of principles. I think things can be going better for me, or I want to get ready for this big challenge I'm going to face. Can you help me put together a team to get myself in the best shape possible? So that team might involve, with your own doctor, someone you trust, whether or not it's a geriatrician, talking about priorities. What are your goals? What's most important to you? What do you want the priorities of your healthcare providers to be? Optimizing the management of your chronic health conditions, of course, including preventative care, like making sure you're up to date on your vaccinations, and talking to your doctor about advanced directives. If you weren't able to speak for yourself, who would you want to speak for you, and what would you want them to say? And there's some suggestions in the resources for some easy to use websites to walk you through the process of an advanced directive. You can also talk with your doctor, your clinic, about finding a pharmacist to consult with. Many clinics have built-in pharmacists. or pharmacists in the community may be able to talk with you to review your medication lists. And as you'll hear about in a few minutes, to make sure that your medications are right for you, that they're still right for you, and that there's not too much, that it's not polypharmacy, that your medications are doing more good than harm for you. Physical and occupational therapists to optimize your fitness, your mobility, your independence, your ability to not just get around, but to get around with the purpose of getting things accomplished that you need accomplished. And then talking to your friendly neighborhood social workers to help outline your needs for support and resources to help you get the support that you need, and to support caregivers. So you can put together your own team, and this is how I would think about doing it. But of course, even better is if all of these people are in the clinic together, working together, all to help you get in the best shape possible. Now, how to talk to your doctor. I want to give you a few tips, and hopefully I won't make your doctors angry in doing so. But this is how a geriatrician would talk to their doctor. Remember to always ask why. I said in the beginning, everything should have a purpose. You know, you don't want to treat numbers for the sake of treating numbers. Treating numbers is important. Treating diseases is important, but there should always be a bigger goal in mind, because you may have to make choices and prioritize things. So why? What's the goal? What's your goal? And what's the doctor's goal when they're suggesting something for you? Always ask why. Because especially as you get older and the list of risks of chronic conditions and diseases and medications gets longer, it's easy to suggest what you could do, what's another medicine you could take, what's a surgery you could have, what's something that you could do. That list of what you could do will get longer and longer. But it doesn't mean that doing all those things will necessarily help you. The hard part is figuring out what of those things is most likely to meet your goals. Not just what can you do, but what should you do? What's most likely to help? And that's about bringing your goals, your doctor's goals into alignment and your priorities into alignment. So ask why, and what's most likely to help you meet your goals. Remember, it's your health, and therefore it's your agenda. You know, your doctor should have an agenda too. They may have things in mind that you haven't thought of. That's important. But ultimately, it's your agenda. What are your priorities? What are your goals? So you should talk with your doctor about what matters most to me. What's the goal of whatever treatment or medicine or whatever it is that we're talking about is. We change, right? As the years go by, our bodies change, our lives change. What may have been perfect for us 20 or 30 years ago may not be the right thing for us now. So always ask once in a while, should we still be doing this? Even if I've been on this medicine for 15 years, is it still the right medicine for me? Is there a better one now? Do I still need it? Always ask, should we still be doing this? And how will this affect all of the other things that I'm doing? So, you know, here's a new problem I'm having. It's important to me. It's getting in the way of my goals. What might we do about it? But also, these options that we're going to think about, how will they affect these other problems I have? Will they make this worse or that better? Will they make another problem more likely to impact my goal? Remember, everything affects everything else. So whenever you're thinking about changing something, doing something new, how does this affect all of the other things, the other medicines, the other medical problems, to make sure that, again, that big picture goal, make sure that everything is working towards that big picture goal. And all of that together adds up to what's the right care for me, not just care I could have or care that you could give me, but what is the right care for me right now as the person I am to meet my goals? That's the most fundamental question of all. So the rest of the session is going to be an incredible display of multidisciplinary wonderfulness with the incredible people you met a few minutes ago. Wendy Katzman, physical therapist at UCSF, Christina Irving, a social worker to talk about Caregiving 101, and Marilyn Stebbins, a pharmacist, how to think like a geriatric pharmacist. And they'll dive into more detail on some of the things I alluded to, like how to make sure that your medicines are the right medicines for you and how to seek out support for you and your caregivers. So thank you very much for your attention, and happy to take some questions.
Thanks, John. We do have some questions. I wanted to start with one of the common things we hear is when you go to the doctor's office as an older adult and your doctor says, well, at your age, these things start to happen. What is a response to that that kind of justification for some sort of procedure or so forth, or some sort of explanation for why something is happening?
Well, nothing is inevitable. And just because it happens more often as we get older doesn't mean that there's nothing that can or should be done about it. My favorite example of this, I'm going to use this opportunity to talk a bit about delirium. Some of you may have had the experience of an older relative going into the hospital and suddenly not being themselves. And maybe even someone who didn't have a wisp of cognitive impairment. Sharp as a tack, but they go into the hospital, they get sick, and they're a completely different person. Hallucinations, delusions, not knowing what's going on. That's called delirium. It's a serious medical condition brought on by acute illness. It's preventable, and we're learning more and more about the molecular pathophysiology that causes it. 30 years ago, we didn't even have a word for it. It was just what happened when old people went into the hospital. They went crazy. It's just the way it is. Nothing to do about it. And it took a very hard-headed young physician scientist named Sharon Inouye to not accept that for an answer. That it's just this is something that happens when we get old. But she almost single-handedly set about defining it as a medical condition, delirium, developing diagnostic criteria for it, learning what caused it, learning how to prevent it, running randomized controlled trials that showed that you could prevent up to half of it, and completely change the way that we think about that problem. So just because it happens more often to older adults doesn't mean it's inevitable, never means it should be blown off as that's just what happens when you get older. And the other way I would answer that question is, it's not about age, right? So there are so many miracles in modern medicine, conditions that we can help, we can fix, we can even cure that decades ago we couldn't. Those are very much accessible to older adults, and those decisions should never be made based on your age, based on the number on your driver's license. They should always be made based on what's more likely to help you than not, based on you as a whole person. What's your overall health? What's your function, your mobility, your independence? What's your life expectancy? If you're in reasonably good health and around 80 or so these days, your life expectancy is 15 to 20 years. So you and your doctor should be thinking with that kind of a horizon in mind, not hey, you're 80, you're just nothing to do anymore. Absolutely not. It's not about your age. It's about you as a whole person.
Great. Ken, do you have a question that's come up that you would like to share?
Yeah, I have, there's a couple of questions that are interesting. They sort of go around the very same thing. One is, when I go to a PCP, often they're young now. My older PCP is retired, and he or she doesn't seem to know a lot about aging. They seem to be in a hurry that they have to see so many patients in a given period of time. How do I approach, and I think you touched on this, John, a little bit, but how do I approach my PCP so that sort of they can be aware more of the total package of how I deal with, or how they help me deal with the issue of geriatrics?
I hope I've given you guys some tools for how to, and again, I hope I don't get hate mail from your doctors, how to approach your doctors as your team members. So remember, it's your life, it's your health. You should have an agenda. And hopefully now you have a few ideas of how to think about that agenda as you age. And you should tell your doctor your agenda. I'd like to talk about this. I'd like you to consider, or like to talk to you about a referral for that. And you can set that agenda and set that agenda in in a whole person, what are your priorities kind of way. So hopefully I've given you a few tools that you can bring to those doctor's visits. And I guess this one secret I'll let off is, doctors are especially primary care doctors are often hurried. They're often rushed. They have to see people very fast. They usually have an agenda in mind too. They have things that they think they need to check off. But the first thing they should be doing is asking, what's your agenda? And you should tell them that when you go into a visit. I have a few things I'd like to ask you about. And that actually helps them because now they have their own goal for those 15 minutes. And there'll be one or two things that they want to make sure to check off. And then there'll be one or two things that you want to check off. And then they feel better about the visit because they know what you want to accomplish, and they can feel like they've accomplished both your goals and their goals too. So going in with an agenda for your doctor can actually be helpful to your doctor.
John, I have one more question, but it maybe it will take several hours to answer. But people are looking for the fountain of youth. But one of the questions that comes up, and I see it all the time, and I'm sure you do, intermittent fasting. And how is this related to aging? And should we be looking into that as an individual?
Well, so some of the more science-oriented folks on the call who have looked into the biology of aging a little bit know that there's a long history of linking fasting and nutrient signals, I'll call them, to mechanisms that regulate aging. This is a big topic in the laboratory that we study. And it's been very fruitful to study. The first generation, this may be news to some folks on the call, but the first generation of drugs specifically targeting aging mechanisms are now in clinical trials. And many of those drugs, about half of them, come from a study of the molecular pathways that are regulated by fasting and nutrient signals. So it's a really interesting bit of science. But about how to think about fasting in your own life, though, is both simpler and more complicated. The simple version, I guess, is it's something that is generally safe for people to try. And if you're on medicines or you have chronic conditions that might make a fast a bit questionable, ask your doctor about it. The more complicated question, though, is what is it actually? What might it actually help with for older adults? And we really don't know. It is the subject of clinical trials, fasting protocols before surgery, before chemotherapy, with the idea of activating these biological pathways. But this is still in the framework of clinical research. And we know that you can imagine, having heard me talk about everything is complicated, everything affects everything else. Something like fasting, we don't want to assume that it would work in an older adult the same way it works in a mouse. You're not a mouse. But it's certainly something that people can try if they're interested in and talk to their doctor about.
Great. Thanks, Ken, for pulling those great questions, and thanks, John, for answering them. Dr. Newman's going to stay on, and we have lots of questions in the Q&A. So maybe we can answer some of those in the Q&A. But we want to bring on our next speaker, and want to thank Dr. Newman for his talk. Really insightful. Thank you so much. Wendy, Dr. Katzman, you're up next, and we'll have some slides to share, so we'll go ahead and let you do that.
Great. All right. I'm going to share my screen, and here we go. John, thank you for your talk. I really appreciated your comprehensive multidisciplinary approach with the patient or the person at the center. I agree with you 100%. And I'm going to talk a little bit more about a physical therapist perspective. And I'm going to start with some of the guidelines, and then I'm going to go into something a little bit more creative about how you may be able to reach those guidelines. And the guidelines currently by the World Health Organization for physical activity that's essential for healthy aging is certainly to avoid inactivity. And physical activity and exercise are key to improving health. Ideally, we should be getting about 150 minutes a week of moderate intensity aerobic activity. That's taking a walk or playing tennis or jogging, 30 minutes, 5 days a week. And there are greater health benefits for more and more vigorous activity. And the recommendation also includes muscle strengthening of all the major muscle groups 2 or more days a week. Now, if we look at the National Osteoporosis Foundation, similarly, guidelines to prevent and treat osteoporosis. If you're 65 years or older and have no limiting health conditions, they're the same, 150 minutes a week of moderate intensity aerobic activity, strength training 2 or more days a week, all the major muscle groups. But they've also added daily posture exercise and balance training to prevent falls. And now if we look at people who actually have osteoporosis or have a history of osteoporotic vertebral fracture, the same guidelines with the addition of strengthening the back extensor muscles every day, posture every day, and teaching people or teaching yourself how to move safely so that you don't injure yourself. So rather than, as a clinician, rather than making people afraid to move because they may fall or they may fracture, really teaching people how they can move safely. Now, interestingly, only 8% of the population in the United States over 65 adhere to these guidelines. Even though there is substantial evidence for benefit from reducing all-cause mortality with up to 10,000 steps a day. However, even 2,000 steps a day decreases risk by 10%. And every 2,000 steps beyond that decreases your risk by another 10%, up to about 7,500 steps a day when things start to level off. And a fun fact or an encouraging fact is that there is a recent study among people who were vaccinated for COVID, and they reported that those who exercised are 25% less likely to be hospitalized for COVID compared to people who have a sedentary lifestyle. While the vaccine prevented serious illness, those who exercised 150 minutes a week were most protected. And as I mentioned before, increasing intensity of exercise improves overall benefits. However, if you do the requisite 30 minutes a day, 5 days a week, and you sit on the couch the rest of the time, it will reduce the benefit of exercise. So I would like to posit, how can you increase your activity throughout the day? And how can you integrate functional exercises to help you meet your goals? And one example is posture exercises. What we know is that you can improve your posture. That was the focus of my research. You can actually reduce the kyphosis in the upper spine. And we can also determine, we also know that an increased curvature in the upper back is associated with reduced impaired physical function. So there's a real benefit for considering your posture and standing up as straight and tall as you can. Thinking about the ABCs, aligning your head over your shoulders, your pelvis, and your feet. Breathing into the pelvis to help to stabilize your spine. The C is correcting the upper back curvature. So lifting your chest and your sternum, spreading your wings and pressing your shoulders down. So one thing I would encourage you to do is every time you stand up nice and tall, take some deep breaths, press your feet into the ground, press your shoulder blades down, and think about standing as straight and as tall as you're able to. These are a few, I call them kyphosis specific exercises. Lying on a foam roller to stretch out the muscles in the front of your chest. Lying over a foam bolster and lifting your torso off of the floor to help to strengthen all of the extensor muscles in the spine that help you stand straighter. Lying on your side and rotating the spine to increase the mobility and the strength in the spinal rotators and extensors. And then practicing things like sit to stand to strengthen your lower extremity muscles, and repeating that multiple times. Every time you get up from a chair, stand up as straight and as tall as you can, sit back down, stand up again, and repeat that to help you strengthen your legs during your activities of daily living. Integrate best posture into your activities. We call this hip hinging, bending at your hips and your knees, keeping your spine straight. So protecting your spine when you bend to pick up your dog, your grandchild, when you load the dishwasher or load the washing machine, keeping your spine straight when you garden, when you put your shoes on, when you load the groceries. Some other examples of good posture and balance exercises that you can integrate during the day is standing up as straight and as tall as you can, reaching the top of your head up towards the ceiling, drawing your belly button into the spine to help to stabilize your spine. The other exercises, I call them the alphabets, doing the W, the T, and the Y exercise several times a day, particularly after you've been sitting and you feel yourself flexing over. Getting on your hands and knees and doing the bird dog to work on your balance as well as the strength in your spinal extensor muscles. And then work on balance exercises. For instance, when you're brushing your teeth at night, hold on to the sink if you need to, stand on one leg, let go of the sink and continue to brush your teeth. Those are static balance exercises. Do dynamic exercises while you're brushing your teeth. Do some sidestepping to the right, sidestepping to the left. Again, thinking about ways that you could integrate some of the posture, balance, and strength guidelines into your activities of daily living. Now, if you do have injury to your spine or you are at risk for vertebral fractures, spine sparing is a way to protect your spine. This is a cartoon of somebody hip hinging, as I mentioned, bending at the hips and the knees, keeping the spine straight. Stepping to turn rather than twisting. Avoid lifting from the ground and lowering to the floor. Don't twist your spine. Don't go to the end of the range. Balancing loads on either side of the body when you're lifting groceries. Supporting the trunk when bending if you need to by using your legs and support your spine. Holding the weight close to your body, not out in front of you, to reduce the load on the spine to protect your spine. Here's a cartoon of somebody lifting on the left. They're hip hinging and they're stepping to turn as they put the laundry down. Whereas on the right, they're keeping their feet planted and they're twisting, which is a recipe for injuring the back. So some tips to increase your physical activity and adherence would be to wear a pedometer. All of these are evidence-based, that if you wear a pedometer, that you will increase your activity during the day, that it is valid to do short bouts of activity. If you're not able to go out for a 30-minute walk, walk for 10 minutes 3 times a day. Cultivating active friends will help you increase your physical activity and adherence to exercise. Set exercise dates with friends. Go out and do a walk and talk for a half an hour a few times a week with friends. Integrate good posture and exercise into activities of daily living. So merely thinking about your posture and standing as straight and as tall as you can 3 times a day is effective at reducing the curvature in your upper back. And lastly, using your body weight. If you don't want to go to the gym, you can do sit to stand repeatedly to help strengthen your leg muscles. You can do wall push-ups. You can do plank exercises. So using your body weight for resistance if you're not able to make it to the gym. So in summary, I think physical activity and exercise are key to improving health. There are strong and consistent messages for positive effects on mortality, disease, and all kinds of health outcomes. Exercise and physical activity can improve your physical function, prevent falls, maintain bone density, bone strength, improve your posture, reduce spinal loads, reduce fractures. And the recommendations are a multi-component exercise program with resistance, aerobic training, balance, and posture, and utilize the tips that we talked about to increase your physical activity and adherence. And here are some resources that you can use. Many of them are very detailed with lots of exercises that you can click on and help you reach your exercise and physical activity goals. And with that, I will stop screen sharing and open it up to any questions that people might have.
Dr. Katzman, thanks so much. I can appreciate making those small changes in your day, the standing while you're brushing your teeth on one foot. We've had some questions, a few here, one in particular around pain and chronic pain and exercise. Can you speak a little bit about sort of maintaining some of these exercises with chronic pain?
Yeah. Wow. I mean, pain is a complicated issue. And I think the nervous system adapts to pain and can adapt to pain in a negative way. Whereas it can become centralized in our nervous system. And even if the peripheral pain is gone, we may maintain a central pain. And one of the best ways to deal with that is to normalize movement and to find ways to move that don't hurt, that you may need to modify your activity, but by doing short bouts of movement, by doing shorter arcs of movement, finding things that don't hurt and reinforcing that helps to reinforce your nervous system and reduces the perception of pain. So I would encourage you, if you find that you're not able to exercise like you might want to because of pain, that you could see a physical therapist who understands how to treat chronic pain and can come up with some of these innovative ways to help you be able to return to a physically active life.
Great. We have a great talk from Dr. Zoffness recording about how it is the cognitive relevance of pain and this sort of working through some mindfulness also to integrate that into your practice. Comments on Tai Chi, improving balance, and a question about what is balance training. So can you comment on those two?
Sure. Tai Chi is a wonderful balance exercise. There is basically there's static balance. There's where you just stand and you might stand on one leg. You might stand on one leg and close your eyes. There is dynamic balance where you will move and challenge yourself dynamically. And there is reactive balance where somebody will push you or you'll stand on a balance board that will disturb your balance and you have to react. So all of them are required to have a high level of balance and an ability to prevent falls. And there's a ton of videos available on balance and balance training. And I hope that answered the question enough.
We'll be sharing your slides following this for people that are looking for these exercises, as well as the list of resources so that people can start to think about these. And there was a great comment from our colleague Kirby Lee, who's retired from UCSF. He said that using smartwatches have been helpful in counting his steps and calories. So I think, yeah, as well. I think we're on to, let's see here, how we're doing on time. So yes, we are moving on. So Dr. Katzman, thank you. There, we have time for questions afterwards, and you can also answer some of the questions in the Q&A box here. All the panelists can. There is a question about calcium supplements that I think we could maybe ask Marilyn and Wendy about as it pertains to bone health. So we'll save that to the end too. I'll make a note of that. And yes, we will definitely send the slides to folks. So we will now move over to Christina Irvin. Thank you so much, Dr. Katzman. It was incredibly helpful to put all of that information in one place. And Christina, you have slides, and we'll let you share those, and I'll move it over to you.
I do. Thank you, Carrie, and really happy to be here with everybody. I am going to go over this in kind of a high-level way about the needs of family caregivers. And when you receive the slides, there are lots of links that will help you dig a little bit deeper into some of the topics that I'm going to go over. So hopefully slides are showing okay. Looks normal. Okay. All right. So when we talk about family caregivers, this is the family, the friends who are stepping in to help provide care. And when we're talking about the care team, family caregivers are a part of that. They are a vital part of the care team. There is a lot of information that the families have for doctors about what they're actually seeing at home, what supports are needed. The challenge is making sure that as a family member, you have permission to actually talk with the doctor. So do you have a power of attorney for healthcare, an advanced healthcare directive in place, so that they are not able to communicate themselves anymore? You are in a position to be able to share and receive information. Having an authorization for release of information on file, something that allows, again, you to share and receive information from the healthcare team. It's really important that you are kind of prepared for those doctor's appointments. I saw some comments in the Q&A around this, having details about how's the medication working? Are there side effects? What are the symptoms you're seeing? What concerns you have? Those are all roles that family caregivers can play within the healthcare team. If you are caring for someone who gets hospitalized, you absolutely should be part of the discharge planning process. Under the CARE Act, family caregiver information should be documented as part of the healthcare record, and you should be receiving relevant information and training upon discharge, and that training and information should be provided in your primary language. So those are all rights that you have as a caregiver during that discharge process to help that person come back home and for you, the caregiver, to have the information that you need. When we look at what caregivers need, kind of a little broad acronym we use is the IRS of caregiving, that every caregiver needs information, respite, and support. We don't generally learn how to be caregivers until we're thrown into that situation. Sometimes very suddenly when there's maybe a stroke or a fall, sometimes very gradually with the progression of dementia or Parkinson's or other chronic health issues. And yet families are supposed to just kind of jump in and provide that care. So getting information about their medical condition, their diagnosis, what's that progression going to look like? What can we expect in the future? That's really important to know to help you plan, to plan for what the needs are going to be, what your role might look like, and what support systems you might need to use in the community. If you are concerned around memory loss, the Alzheimer's Disease Research Centers can be a great place to get that really thorough evaluation around cognitive impairment, but connecting with any of the disease-specific organizations, Parkinson's Association, Stroke Association, they all have a lot of great online education and training that can help you and the person you're caring for prepare for what's to come. I know we're going to hear a little bit more about medication management in a moment, but families are often the ones who are helping someone take their medications, checking sometimes vital signs, blood sugar, blood pressure, and again, without a lot of training. We say families providing care that nurses and LVNs and CNAs do, and no one maybe really taught them how to do it. Pharmacists and nurses are a fantastic resource for families to connect with, and occupational and physical therapists as well. And it can be, again, they might be providing support for the person needing care, but they can also provide support and training for that family caregiver. And it is possible to have the doctor authorize visits for the purpose of the caregiver getting training on how to help somebody, transfer from a wheelchair to a chair, get in and out of the shower, help them with other personal tasks. You can have those therapy visits for the purpose of training, transfer skills training, education for the caregiver, and that can be covered. And then there's some links in here to some good videos that can provide some of that informational training as well. Legal planning information. This is a step that you need to take early. By the time you need to actually use these legal documents, it is generally too late to actually sign them and complete them. So who is going to manage someone's financial care, their health care, if they are not able to do so themselves? So do you have a power of attorney for finances? Do you have an advanced healthcare directive? Depending on your situation, do you need a trust? Conservatorships, always last case scenario. But if we don't do some of this other legal planning, often we find that people are left with no other alternative. Most counties are going to have a senior legal service program that can provide some good general information about these types of legal documents. But then if you need to consult with an elder law attorney, depending on the complexity, there are some specific referral services for elder law attorneys and estate planning attorneys, rather than just kind of a general bar association referral. So a big area when we're thinking about kind of information that's needed is how do we actually pay for care? And this could be an entire hour-long presentation itself. So again, very high level, but I'm going to give you with some information about where do you go for more. Medicare, covering your hospital visits, your doctor visits, those therapy visits, prescriptions. It does not pay for ongoing long-term care. It is acute short-term care only. So when people start to need long-term care in a facility or even at home, generally not going to get it under Medicare. There can be additional Medicare benefits depending on the plan you have. In California, HICAP, the Health Insurance Counseling and Advocacy Program, is a wonderful resource around understanding Medicare. You're looking outside of California, every state has it. It's called the SHIP program. California always likes to rename things specifically in our state, but SHIP is State Health Insurance Program, and so provides similar services. And then for UC employees, there's specifically a healthcare facilitators program. Medi-Cal has some really unique eligibility that is not available through the federal Medicaid program. The asset limit was actually increased this year to $130,000 for a single individual to be able to qualify for Medi-Cal. And then depending on your income, you may or may not have a share of cost. Medi-Cal and Medicaid broadly can help pay for in-home care long-term, as well as pay for long-term skilled nursing facility level of care. And Canner is a fantastic resource for Medi-Cal information. Not a lot of people have long-term care insurance. If you do, or the person you're caring for does, look into it early. What is covered? Is there an eligibility period you have to pay for care for first? What's the daily cap? What's the maximum cap that you can use? You want to understand those policy restrictions before you actually need to start utilizing it. And if you or the person you're caring for is a veteran, again, connect early to your county veteran service office. They can help understand what benefits are available, help advocate for the veteran, and help make those connections to services. A lot of people think that you have to have a service-connected disability to access some of these long-term benefits through the VA, and that is not necessarily true. So worth exploring early. And kind of going into that is information about community resources. I'm going to talk a bit more specifically about how do you find these depending on where you live, but understanding that as a family caregiver, you might be providing a lot does not mean you have to do it all the time. There are programs that help with meal delivery, transportation, making changes to the home to keep it safe and accessible. Do you know how to access hospice or palliative care resources within your healthcare team? Again, how to advocate for those home health services like physical therapy or home health aides, and making sure that you're getting access to those. So important things to start exploring before you actually need it, because these are hard systems to navigate through. Our healthcare system is not set up well for people to easily access benefits in a crisis. So you really want to start looking into what's available where you live as soon as you start to understand what the needs are. And then the second thing caregivers need is respite. It means getting a break. You don't want to wait till you're overwhelmed or exhausted before you get some time off. That could be from family members, from friends, through hiring in-home care through an agency, through somebody you find privately. If you qualify for Medi-Cal or Medicaid through the in-home support services program, or through the VA programs as well. So finding those ways to get regular breaks, again, before you're overwhelmed and burned out. Respite can also be provided in a care facility, assisted living, boarding care homes. They often will allow people to come in for short-term stays. So when the caregiver has health issues or needs to travel, sometimes this can be really useful. Adult day programs are a fantastic resource in the community. It's a place for people to go where they can get socialization, stimulation. They might have access to a physical therapist. So it can be a great outlet for somebody needing care, as well as giving the caregiver a break. And then there are programs that help pay for respite, to give families grants to get a little bit of time off. If you're in the Bay Area, Family Caregiver Alliance has some of these. Throughout California, the caregiver resource centers, and then everywhere through the area agencies on aging, there is a national family caregiver support program that can provide some respite funding as well. And then the last kind of big bucket area for caregivers is support. You cannot do this alone. It can feel like one more thing to do when you have to take care of yourself, which is why a lot of caregivers don't access support and help for themselves, not just for the person that they're caring for. But the longer someone's in a caregiving role, sometimes the more isolated they can be. We see high rates of depression and loneliness amongst family caregivers. So really connecting for support is vital. Support groups are a great way to connect with other caregivers and to learn from each other. Senior centers, hospitals, disease-specific organizations, caregiver resource centers, we all have support groups. The Friendship Line is a 24-hour crisis line for those 60 and over. So anybody who's in kind of emotional crisis, there is a phone number you can call that has an understanding of issues related to aging and caregiving. And then there are other access to counseling programs in the community, through your insurance, through an employee assistance program, lots of ways to find individual counseling. So I've talked really kind of broadly about some of these resources, knowing that people are living potentially in lots of different locations. So if you really are ready to drill down to how do I find that caregiver grant? How do I find this transportation or meal programs? If you are in California, the caregiver resource centers exist all throughout the state. Family Caregiver Alliance is the one for the Bay Area. Area agencies on aging are your local kind of information and referral programs, as well as providing direct services. Outside of California, we have a services by state guide, and as well as elder care locator, and those will help you drill down to those programs where you live. This will also be sent out in your resources, but again, if you're looking for more of those topics and tips related to some of these common issues around caregiving, we have those kind of collated for the ones that come up most often. And so there's additional resources that you'll see here. And then before I jump over to questions, I'll just leave you a little bit of information about FCA. We provide more direct services in the Bay Area, but also will guide people nationally to their local caregiver support programs, as well as the access to education. Really quick overview around caregiving, but again, lots more information that you can dig into when you receive this. And with that, I will stop share and open up to questions.
Yeah, thanks, Christina. This is just so wonderful. And everyone knows we will send this material to you as a PDF following the event. I wanted to ask you a little bit. I think the Family Caregiver Alliance, it brings together so many great resources. And I wondered what how you would guide people for care managers, geriatric care managers on their, these tend to cost, they can be couple $100 an hour to have a care manager. But for people that don't have family or don't have caregivers, or just want to have the resources to pay for a geriatric care manager, do you want to speak to that a little bit?
Sure. Geriatric care managers are a great resource. The Aging Life Care Association is a national association of geriatric care managers. So it's a way to find potential care managers where you live, and can stick that in the chat after this section is over. They are a great resource for what you need them to do. So they can come in, do a full assessment, really, I don't say take over, but really kind of step in and help manage everything for somebody, be the one to hire in-home help, be the one to be there at doctor's visits with you. If you don't need as much help right now, but you're planning for, well, what happens if I no longer can be as active in my care, they can step in more at that point. So the level of intensity that they provide really varies depending on need. There is a cost for them, so it can add up, and it is not necessarily cheap. Some counties will have kind of county-funded case management programs that will either be free or low cost. It varies quite a bit county by county, so there is no consistency on the availability of that. So outside of looking at the Aging Life Care Association, that's where talking to your local area agency on aging to explore what sort of case management programs might be available can be helpful. And we are seeing a lot more groups at senior centers and through the Villages movement kind of come together around, they're called like solo agers. And so I think we're going to see a lot more of those kind of community-based groups really kind of grow naturally to provide that support for each other. So I'd look at those resources as well.
We can also share the link to the Villages, which is a volunteer-driven organization by seniors taking care of seniors in the community to help people stay in their homes. And it's they're wonderful, robust. We partner with our local one, Ashby Village. We had a question. What is the Friendship Line number? We'll give that to you following the event. I actually volunteered there, I think probably 15 years ago. I was a Friendship Line, and it's a wonderful experience to be able to help people and stay connected and feel connected to their community. this is that challenging question about wait lists and long lines to be able to get access to services. So when you do get a request, you're told, yes, the service is available, but it might be a multi-year waiting. So do you have any tips or anything to say about that?
That is the piece about starting to access these things early, not waiting until you actually need to use those services. We do take calls from caregivers nationally, and I know our national staff, they know off the top of their head what states in particular tend to have really long wait lists, but even in the Bay Area, we often do. I think we've seen improvement because the state funding coming down, but yeah, access those services early. If you come up on the wait list and you realize, actually, we're doing okay and we don't need it, you're not taking away that service from anybody. You can decline, you can step back and say, actually, put me back on the wait list. We're not quite ready yet. Things have changed. But reach out early, start to explore what's available exactly where you live. And yeah, get on those wait lists because I think we're going to see that increase unless we get a lot more funding coming down.
That's right. Make a plan, right?
Yeah.
And so the question is there a clear path on locating the help? I think you mentioned the elder care locator, which is a number we will give to folks as a central point of contact. But did you want to leave folks with where is that clear path on locating the help? Or is there a clear path?
I mean, to some extent, there's not a clear path there. It's a little fuzzy. So, that's, again, start early. Elder care locator, that's going to take you to your local area agency on aging, wherever you live. That's really kind of your starting point. The area agencies on aging get funding under the Older Americans Act for the whole range of services that are available. So that's kind of your starting point, but also being able to say, here's the things that I want to know more about. Either here's the things that are challenging for us now, or what I'm worried about happening in the future, so that you can either ask more specifically about services. You might ask them, is there a resource guide you can send me? Are there presentations that are happening about what's available where we live? And just start getting connected to those programs now. Even if it might feel like it's just one more piece of mail or email that you got, you will have a link then as you start to need more information.
Such good advice. Okay, there's a few more questions, but I'm hoping maybe you can answer some of them in the Q&A, and we'll move on now to Marilyn. Thank you so much, Christina. Such great information, so much in one place. And once again, we'll give everybody the slides and material afterwards to have these links and phone numbers. So thank you so much. Marilyn, then? Yeah.
I couldn't hear you for a moment. Okay, let me go ahead and
Yes.
share my screen. And it's such a privilege to be here with this panel. I can't say how delighted I am, having worked in an interprofessional geriatric clinic for many years as the pharmacist. The information you're getting today is just amazing. So listen up. I think from my perspective, it's very, very difficult to think about how in the world to cover medications in the geriatric world across the continuum of care and medication safety in 10 minutes, but let's try it. I think many of you probably have either witnessed this with your own families, if you've had aging parents, or perhaps with yourself, the crazy pill bottles that you may see in the way people manage their medications. And I will say the body is one resilient thing, because some of the things we do to it and how we misuse it and how it survives all of that. And if you can see this is actually a picture of the medicine bottle of what a patient we had was actually taking each day, and we couldn't even identify what it was. So I want to just share several tips, and I can't emphasize enough how being your own geriatrician or your family member's own geriatrician, how important that is, because knowledge is power. And with medications, you can't have enough knowledge, I think. And when you look at it and you think about what you're putting in your body or what you're asking your family member to put in their body, and if you don't know about it, how unsafe that can be. So I want to start off with what is my pet peeve in the healthcare system, and that is the accurate medication list. And I think it's critical for everyone to have on themselves, in whatever fashion they can, an accurate and portable and accessible medication list. And that means you need to be knowledgeable enough to know your medications, know how to write them down, know what strength you take, how you take them, and questions you may have about them. And it has to be with you when you go to provider visits, because the important thing is, I don't know how many of you have been given that sheet of paper when you walk into the doctor's office. It says, look at this and tell us if you're still on all of these medicines. You cross them all out and say, nope, not on this, I'm on these. And the next time you come in, that same list comes back to you. And you really do need to insist that your medication list that is in your doctor's electronic medical record is actually the list of medications you are taking. And again, be persistent. You're really going to have to be your own best advocate to ensure safety and to ensure accuracy, because in today's healthcare environment, I wish we could say that you were only seeing one provider, but there's multiple prescribers in there. And that even lends itself to an environment where medication safety is definitely affected. The other thing I want to say is, on that medication list, you need to put all of your over-the-counter medications and supplements. Many people feel that because something is over-the-counter, it's safe. And it may be safe, but it also may have drug interactions. There may be reasons why your kidney function as you age isn't the same as it was when you were younger. And there's medications that are over-the-counter that we don't advise older patients to take because of things like kidney function that you were probably taking when you were younger. And I think that it's really important to include these on your list. Now, I will tell you that many of your providers may not know the drug interactions with supplements, and they may not understand those, but your pharmacist should be able to look those up. So if you're someone who is on multiple supplements, I highly recommend that you take your list into your pharmacist and you ask them to run a drug interaction checker using their reference of natural medicines to see if these interact with your medications, because it is something I come across very often, that people are on multiple medications that interact, that they have no idea that they actually do. The next piece of medication safety is, how do I remember to take my medications? Or did I possibly take them and now I can't remember? And what happens if I double dose? Should I just not take them? And I think this is a big conundrum, because I don't think this gentleman is too far off the mark when we look at what many people are taking today when it comes to medications, which is, I think, rather tragic, because I think this does set us up for a rather unsafe environment. So how do you remember to take your medications? Number one, set up a reminder system. Phones, smartwatches, all have alarms. You can also set them up to blink in case hearing is a problem, and so that you see the blinking as well when it's time to take medication. I always tell people to pair their medication taking with another daily habit. So make sure that you're pairing these so that you remember more easily. So if you need to take medication with food at breakfast, make sure that those medications are at that breakfast table so you don't forget. If morning is the time you take your medications, or evening is the time, and you always brush your teeth in the morning and the evening, you could put your medications near that and make sure you pair that habit with medication taking. So again, find a behavior, and not everybody's going to have the same daily behaviors, but find a behavior and pair it with your medication taking. And lastly, figure out a system that works for you. Many people will use a pill box because they can fill that pill box and then they can look at it and determine, did I take my medication today or not? Because those pills are still in there if you forgot to take them. That's one of the reasons I like a pill box. Other people say, I don't need a pill box. I only take 1 or 2 medications. Well, that's okay if you have a system. Turn your medication bottle upside down after you take your medication. And then you know if that medication bottle is upside down, you took it. If it's still sitting straight up, you probably didn't. So again, be thinking about these things that can help you remember and keep yourself safe from either taking too much medication or forgetting to take your medication. There are many systems out there that you can use, but I will tell you, finding the right system for you and also finding people to help you with that. A pill box can be daunting, especially if you take medications multiple times a day and multiple medications. Having someone help you double check once a week when you fill that pill box, or you may be the caregiver filling the pill box, always look for that double check. As a pharmacist, we have double check systems when we dispense medications, but the ultimate dispensing of medications is you taking it yourself. And so it's really important that you ensure that your medication system is accurate. And so getting someone to double check it is a great idea as well. Moving on from there, what do I do with these old medications? How many of you have a medicine cabinet that is filled with medications that you just don't want to throw away because you paid good money for them, you might need them again, or you've got someone in the house that doesn't even live there any longer, your adult children, you still have old antibiotics or something in the cabinet from them. It really is not safe to flush medication into our waste system. We know that we shouldn't be doing that. I will tell you that we are in an era that I am so pleased to say that we have resources now to dispose safely of medications. And you can dispose of medications safely, whether they're controlled substances or narcotics, or whether they're just simple prescription medications or over-the-counter medications. Now, in almost all pharmacies, you will see what's called a take-back kiosk. And that take-back kiosk is a place that you can go, it looks like a mailbox, and you can simply put your old medications in there safely and securely. And I've put a resource in your resource tab that takes you to this page that tells you where you can dispose of unused medications. You can search by pharmacy name, city, or zip code, and it'll tell you where you can take your medications. In the past, you had to take them to fire stations or police stations, but now the place you visit, likely more often than any place other than the grocery store, is your pharmacy. And many pharmacies have these take-back kiosks. So again, I want to emphasize the importance of safety from the day you get a prescription to the day you finish taking that medication and no longer need it and need to find a way to dispose of it. And in parting, because I am the last speaker and I'm happy to answer any questions that you may have, I want to just really bring up one term, which we call deprescribing in geriatric pharmacy. And I think everyone deserves to know this term. And that is because I think we should always, as providers who are prescribing and dispensing medications, always take a deep look at what we could deprescribe. What does that patient no longer need, or what now can we do to simplify their medication regimen? So if you learn that term, it's a great way to be your own geriatrician, to ask your doctor or your nurse practitioner or physician's assistant, are there any medications we can deprescribe today? Is there anything we can take away? We used to have a rule in our geriatric clinic that was, we wanted a net negative or a net zero at the end of a visit. If we were going to add a medicine, we wanted to be able to take one away, because we knew what the pill burden was like, not only on the patients and their caregivers, but also on your body. And so it's really important to think of this term, deprescribing, and challenge your providers to look at your medication list and think, is there anything on there that I no longer really need? And with that, I'm going to leave you with some resources with respect to med organization, accurate med lists, and medication safety, as well as the site of disposing unused medications. And with that, I'm happy to take any questions.
Thank you so much, Marilyn. That was fantastic, and really drew out the highlights. I think we do have some questions here, also some compliments, great suggestions on the medications. Another person said, I don't turn off my nightlight until I've swallowed my morning pills. So people have processes that work for them. What about injectable medications in terms of returning those or dropping those off?
Injectable medications can be tricky. You should ask your pharmacy, but we always also tell people that they can take an injectable medication and squirt the remaining medication into a plastic bag that has either kitty litter, coffee grounds, something that nobody would want to take. Squirt it into that, seal it off, and you can go ahead and dispose of that medication either in the take back kiosk at the pharmacy, or you can actually put that in your trash, but not the needle. The needle needs to go in a safe container, and that safe container, if you don't have a sharps container that you can then take to your pharmacy when it's full, you can use a bleach bottle and take and throw your needle into the bleach bottle. And then you can also use that as sort of your sharps container that's a safe way to either take it to your pharmacy or dispose of it with a lid on it, because that is also not something that someone's going to be able to get a hold of. So again, a very thick plastic bottle, like a bleach bottle, you can put your needles in, but the medication in it, you want to squirt into either kitty litter, coffee grounds, and put in as a Ziploc bag.
That's great. Very helpful. Someone pointed out to also, when you're reporting your drugs to your doctor, include CBD and other
absolutely
drugs, anything that you're taking because of those. How do we know, or how do I know if my medications have interactions?
You don't necessarily, although unless you're one of those people that reads the package insert that comes with their prescriptions, which is this long and this big. But there are, I think that you can find those on a package insert. You should always ask if there are any drug interactions when you pick up a medication at your pharmacy. Your pharmacist also, one of the reasons to use a single pharmacy is because the pharmacist, when they enter that prescription, it will automatically be checked with a drug interaction checker for the medications they have on file that you would be taking. So that's my plug for using a single pharmacy. I know that's not always possible, but if you use multiple pharmacies, be sure those pharmacies know the other medications you take so that they can do a drug interaction check on your medications. Now, that doesn't work if they don't have your over-the-counter and supplements. those get very tricky, and you have to actually ask them, because the interaction checker for natural medicines is in a different place. It's not a simple interaction checker.
That's
Um,
helpful. We have a couple questions that Ken, about supplements. Yeah, unless you.
Yeah,
Yeah.
this is on the same, the public and particularly aging are being faced every day with pitches for cognitive impairment supplements and bone supplements and so on and so forth. And I think the consumer has a real difficulty. The claims are terrific that are made in the media, but of course, there's no science to back that up. What advice would you give to us about these pitches? We all want to maintain our cognitive skills. We want to maintain our bone strength and so forth. Before we start taking these, we want to avoid macular degeneration and so forth. Well, what is your advice to us that are being bombarded with this multi-billion-dollar business that wants us to buy all these drugs?
I wish I could tell you it's easy, because I get caught up in it too as I age. I look at these and I am an educated pharmacist, and I go in and I have a difficult time myself. So I think part of me says anything that sounds too good to be true probably is too good to be true when it's on the over-the-counter market. There's not a lot of regulation. People don't realize that over-the-counter and supplements are not FDA approved. And the clinical trials, that they don't need to have the clinical trials to make their claims. So it's buyer beware. I would tell you to read labels and look at what's on a label, look at what the claims are on a label. Basically try to do your homework and look to see if you can find any more information on that. The other thing I will tell you is so many of these have so many different components to them. I had a patient the other day that had 4 sources of calcium and 5 sources of vitamin D in their different supplements, and they were being overdosed on vitamin D, which is a fat-soluble vitamin that can be very dangerous. Too much calcium is dangerous. We should be getting our calcium from our nutrition, calcium and vitamin D, as much as we can, because those have drug interactions as well. And we don't know all of the benefits to the problems that we may have from a cardiovascular standpoint from too much calcium. So I wish I could give you a better answer, but I really believe that more is not better. We've got to be very careful with that. And we have to use some common sense. If these claims were so phenomenal, we should probably have seen them in a prescription drug at some point. And always take something to your pharmacy, because it's your most accessible place, and ask them if they can take a look at it and look to see if there are any interactions, and if from a safety standpoint, you're okay taking that medication.
Well, we're at little over quarter of the hour. I could go on forever. It's such a shame to end this panel. It's each one of you have really shown how a team works and comes together, and that the retiree is a part of that team. In fact, I think they have to be a very assertive part of that team, especially if they're on their own otherwise. So hopefully today we've given you some starting points to get your things in order. We want to thank our panelists for today and respect people's time. We'll end on time, even though I think we could go on forever. And we will be sending the slides and a copy of the video of today's talk, and the slides include all the resources in there too. So Ken, any last words? Want to thank you for organizing today.
It's just been a great panel. And as you say, we probably could go on forever. Really appreciate all of you, the panelists, for providing great tips. I think the review slides will be helpful to many, and thank you. And as Carrie, it's time to end, and maybe we'll have more in the future.
Great to see everyone, and great to see everyone online today, everyone who participated. Wonderful to see y'all. Take care, everybody. Be safe. Thank you.